Just put some comments in the chat box if you can hear me. Yeah, that's great, thanks. So we've had to just change the order slightly. Dr. Malik is unfortunately just seeing an unwell patient on the ICU. He'll be joining us later in the morning. So we've moved my session to the middle of the morning. Renal medicine is an absolutely vast topic, and one of the things that I was quite daunted by going into my FICM exam was just the size of the curriculum as a whole, but then how everything is quite interlinked. So I thought as part of this morning it would be good to put together a session based on what I'd experienced has come up in the FICM exam before with regard to renal. I've always enjoyed those sessions at the previous regional teachings. So I've got quite a short session just highlighting kind of how I broke up topics like renal into kind of little chunks so you can work on them towards your exam. I've also included some example OSCE stations from the FICM OSCE. Some of them are example questions from the college website, but just to give a guide about how an OSCE station might work. And one of the stations came up in my exam in October last year, which I thought might be quite useful. So as before, if anyone's got any questions, we've got about 6 screens in front of us here at the moment. So if anyone's got any questions, just put them in the chat box, or you can use the question and answer function, but the chat box is probably better. Put those questions in there, and then I'll try, and if I notice them during the talk, I'll address them. If not, we'll just address them at the end of the session. And then going into the morning, we're going to have another short break, and then we're going to have Dr. Malik talking about renal replacement therapy on the ICU. Okay. So the talk's going to summarise FICM syllabus topics in relation to renal. I'm going to highlight as I go along important classification systems to know, discuss guidelines and protocols that I found useful for when I was revising, and appropriate care bundles and safety projects. And at the end, there's a short summary on what I felt was probably the most important studies to know about in relation to renal. Some of those studies will be discussed in more detail in Dr. Malik's talk, particularly focusing on things like early versus late filtration. And as I said, I'm going to try and include some real exam questions. When we get to the questions, it's going to be a bit clunky again, because I'm going to ask you some questions, and if you just post your answer into the chat box, I'll be able to see the answers coming in. Now, we can't see answers across the across all of the participants. There's currently 46 people logged in, but I can see them, and I'll respond with people's answers, and we'll kind of try and do it like that. So, but such is the current COVID era. So when I first started revising for the FICM, my first point of call was the FICM website to look at the syllabus. And I'm sure we're all aware we're looking at the sort of 90 or so domains on our e-portfolios. It's a very large curriculum of topics, but often examined are the competencies from the syllabus. So here in this table, I've summarised what we kind of need to know about renal as ICM trainees. So, recognise a patient with acute renal failure and manage them. We need to be aware about management of intoxication with drugs and environmental toxins. And then renal replacement therapy, as I said, that's going to be addressed in a later talk. OSCE exams often start with a piece of equipment and then descend into a discussion about the practicality of the equipment and treatment that you can deliver. So we'll show an example of one of those stations later. I haven't touched much on solid organ renal transplant because this involves quite a lot of pharmacology to do with immunosuppressants. So that's something that I have left out towards the end of the talk. But again, management of renal transplant patients on ICU is very common. So that's one to watch out for. So. On the bottom of the curriculum as well, there's also for example, in every stage of ICM training, there's something called the basic science competencies. And coming from my anaesthetic background, I always break those things down into these topics. Certainly in the written exam, you might be asked questions about renal anatomy, perhaps, and the vasculature. Pharmacology is important. Questions on diuretics come up. Management of anticoagulation in terms of how citrate works in hemofiltration. And again, Dr. Malik will go into more detail about this. We often use heparin, and there are other other drugs such as Flolan or prostacyclin, which can be used for anticoagulation in hemofiltration. It's important to have a working knowledge of the pharmacology of how toxins cause their effect, and what they actually do to the kidney, because that often affects how we treat those patients. immunosuppressive pharmacology was one of those nightmare questions for me, particularly in the FRCA, because they're often extremely complicated. As we've just heard from Dr. Edie's talk, it's important to know about basic pharmacology of how they work and interactions. Now, apart from highlighting this, I haven't gone into detail on that talk because that's an entire different talk on its own. I didn't get asked many questions in my written exams about very sort of basic physiology, but it's not unreasonable to have an awareness of how the nephron works, how renal blood flow is autoregulated, the glomerulus, and to have an idea about how we actually measure EGFR and those kind of things. Physics and equipment commonly come up in the OSCE. Again, we're going to address all the different modalities of renal replacement therapy we can provide on ICU or in a later talk. But it's not unusual to be presented with a picture of, for example, a dialysis catheter or something like that. And we'll see more of that later. So again, as I say, the curriculum is extremely broad, and this is from my list of kind of topic things when I was preparing for the exam. Management of electrolyte abnormality are kind of linked in with renal medicine. A patient with renal failure may have emergencies such as hyperkalemia to manage. One of my Viva stations on management of the hypercalcemic patient. And yeah, so you need to have in your head a protocol, stepwise approach for phosphate, magnesium, calcium, potassium, sodium emergencies. Specifically, these toxins, toxicity with ethylene glycol, methanol, effects of rhabdomyolysis secondary to MDMA, and contrast-induced nephropathy. There's questions on those pop up as well. There's a broad range of hematological conditions that cause significant AKI. One of my Viva stations was on the difference between HUS and TTP, and there's a short section on management of how to, first of all, stabilize the patient, how to treat the effects of the AKI, but then there's also detail on, what specific investigations would you do to differentiate between the two. So hematological conditions come in as well. I had an OSCE station on tumor lysis syndrome and management of the ensuing electrolyte problems secondary to that, and preventative measures such as allopurinol, rasburicase, significant hydration. As we'll see later, questions on rhabdomyolysis are very common and how you manage that. And as we see from Dr. Edie's talk just now, questions on specific tests for certain types of vasculitis often come up in the MCQ SBA. So first focusing on domain 3.3. AKI is a massive problem in the UK, and we see lots of it on our ICUs. It causes 100,000 associated deaths per year, according to data from 2018, looking at where acute kidney injury is mentioned as in relation to the cause of death. And that goes on to renal registry data. Since 2014, we're all familiar with the AKI alerts that we receive on our systems. And according to renal registry data, about 1.5 million of those alerts are generated in 2018. About 70 in 1,000 acute admissions coming into medicine, surgery, will all have AKI, so significant problem. And there's quite a significant mortality increase if you have an AKI stage 3 at any point in your admission. If you develop AKI in hospital, it's worse than coming in with AKI. And so, we need to pay close attention to it, manage it urgently. So the curriculum talks about identifying at-risk groups. And as I'm sure you're all aware, there's a huge list of patients, who are at risk of developing AKI. In terms of a useful guideline, I did a lot of reading of NICE clinical guideline NG148. So it's a good go-to, quite succinct summary. And their first section is recognise the patient at risk. So obviously, that's a patient with chronic kidney disease, patient who's got multiple comorbidities, particularly heart failure, patients with previous AKI. The others are obviously, oliguria. That patient is obviously at risk of AKI as a cause of their oliguria. There's others who we perhaps don't think of so much. Patients who've been on the ward with low GCS, who perhaps may have not had access to fluids. Hypovolemia is obviously a very obvious cause. We talked about precipitant drugs in the earlier talk. It's interesting to hear Dr. Edie talk about contrast media, because I've heard a lot of people say recently that CIN doesn't really exist, but obviously he feels it does, and it causes a lot of his workload, really. And obstruction as well is important to keep an eye on. Every care bundle in ICU has consideration of sepsis, and we'll talk a bit about that later. And also the guideline highlights those who are very old or very young. And in particular, there is a pediatric section on there. You don't really think about AKI in littlies, but it occurs quite frequently. In terms of classification systems of severity of AKI, then the one that's come up most frequently in my exam is in reference to the kidney disease improving global outcomes staging system. This is the most common staging system that's, I would probably have this in your memory for your exam if you can. And I'll just leave you a few seconds to look at this table. Classified according to serum creatinine or urine output. There are other systems that exist, such as the risk injury failure loss or end stage system. There's also the AKIN, acute kidney injury network scoring system that are that may also crop up. One of my OSCE stations looked at a patient who had was presenting with bloods indicating AKI, and they were after a stepwise approach as to how you would manage that patient. There's lots of national patient safety initiatives that are useful. One of the ones that I've got a copy of here is the Think Kidneys project, which is a collaboration between the NHS and UK Renal Registry and renal physicians nationwide, which has assessment, initial treatment, investigation and management bundles. So it's worth having a look through this. Locally in Leeds, where I've done a lot of my training, they initiated the Stop AKI bundle, but they all often incorporate the same initial management priorities. The first thing to do is to ensure the patient has an ABC assessment. As any kind of acute medical emergency, it's important to think of ABC and are there any immediate problems that need to be recognised. They need to be somewhere where they can be observed, particularly if they're very unwell. You consider high dependency setting, for example, and sepsis comes in really early. As Dr. Eady was mentioning in his talk, it's one of the leading causes of AKI. One of the stations that I had, where you'd only be told that the patient had a 1,000 ml residual urine volume, upon saying that you put a catheter in and measure their or do a bladder scan or palpate their bladder. That information only came to light when you said you do those things. So always think about obstruction, particularly if it's a patient or a scenario in an exam where you're being asked to see a patient not on ICU. Yes, we're used to all our patients having catheters in, for example, but always think about obstruction. Even on ICU, always think about a blocked catheter as a possible cause of deterioration. Treat sepsis, once you've completed your sepsis bundle, ensure you've ruled out hypovolemia and hypotension and addressed that with either fluid replacement or vasopressors. All of the bundles talk about doing a nephrotoxic drug chart review. One of the things I often forget to do is I'll look for nephrotoxic drugs in the drug chart, but I'll often forget to actually look for the routine medications or other medications, for example, commonly antibiotics, to actually dose adjust those as well, particularly if we go on to hemofiltration. The doses of those drugs may need to change 2 or 3 times during the patient journey. And always think about relieving obstruction. Renal tract ultrasound is obviously part of the initial workup of AKI that, again, is important to organise. I'm going to leave out investigations because we've gone through those in the previous lecture from Dr. Eady, and management and referral again. It's discussed in the guideline, but usually if a patient isn't responding to your initial management measures on the ward, particularly once you've corrected volume status, they may still be hypotensive, they may need further referral to ICU. If the patient has a deteriorating AKI and does not respond to these initial measures, then they probably need discussion with the renal team or the intensivist. So yeah, I recommend having a look at the Think Kidneys bundle. It's very good. There's a bullet point checklist, and a lot of the UK-wide AKI care bundles are based on this document. So have a read of that for your exam. Right, so we're going to move into an OSCE question now, just to break things up. And again, if you could just answer, in the question and answer box here, have a look at this information in front of you here. See what you think. So a 19-year-old is found unconscious at home. He's been brought to the emergency department by paramedics. This is a real college OSCE station. Initial bloods on admission to the department show so slightly high urea, slightly low sodium, very high potassium, low bicarbonate, AKI indicated by its creatinine. The other bloods and the ECG. So post some answers. What can you see? What do you think's going on here? Yeah. Yeah. So a lot of people are saying hyperkalemia, exactly. You then get asked what's common is to be presented with clinical information like this. Someone's mentioned rhabdomyolysis. Yes, that's a possibility, isn't it? Yeah, yeah. So you then get, after your clinical information, the examiner will ask you a few set questions. So here we go. So fire off some answers on the question answer box here. So Kat's mentioned quite rightly, could it be AKI secondary to a toxin? The 19-year-old mentioned MDMA. The brief for this station says that once someone's mentioned MDMA or neuroleptic malignant syndrome or something along those lines, the patient is normothermic. Considering the history, what's the most significant metabolic abnormality? And as lots of people have said on the question answer thing here, it's hyperkalemia. Suggests a likely cause. So he's been found at home on the floor. You know, I guess there's a presumed long lie there. So as some people have already indicated, there's a high likelihood of rhabdomyolysis. And if you could just list for me in the question answer box, what treatments would you give for this patient? And in what order? What's your priority of order? Whoa, yeah, there we go. Yeah, so lots of people saying calcium gluconate. Yeah. Fine, so calcium gluconate. People are obviously treating with insulin dextrose as the initial measure. Any other treatments, if those aren't successful, perhaps? Yeah, so people are saying bicarbonate. Yeah, that's so bicarbonate kind of fell off the management of rhabdomyolysis for a period. There are some people who still like giving bicarbonate to alkalize the urine, reduce cast formation, for example. But the college wanted here insulin dextrose, intravenous calcium, hemofiltration or hemodialysis, plus minus bicarbonate, plus minus overhydration. Okay. What investigation diagnostic of rhabdomyolysis? So, yeah, people saying yeah, CK. So CK, you'd expect this to be in the thousands. Fine. Other things you could do are do CTs if you're still concerned about an ongoing creatinine rise after the patient in hospital. There's usually a lag before it starts to fall, but yeah, always think about other muscle compartments where things are still progressing and you're still developing a CK rise. But yeah, so that's again an example of an OSCE station off the college website, which takes you through being presented with some clinical information and then managing them in relation to renal medicine. I think this is really unlikely to come up in an exam, but it's important to mention that NICE have also released a rapid kind of management guideline in relation to COVID-19. And this is probably why we're all sat here doing this remotely rather than having a face-to-face teaching session. So essentially looking through this COVID-19 guideline from NICE, I was looking to see if there were any gems that were different to how we might manage the COVID-19 patient presenting with AKI. But essentially they're very, very much reinforcing use of a standard care bundle and all the things that we would probably consider. There's the definition there of AKI being greater than 26 millimole creatinine increase or an increase of 50% or more of baseline, or obviously urine output based criteria. They fit back into the KDIGO assessments that we mentioned. One thing this guideline does mention is doing urine analysis that often gets missed from the initial investigation, but as we talked about in Dr. Reedy's talk, that can often be difficult in patients who've got catheter samples due to the confounding protein in blood that would cause. But aside from the basic initial assessment and management of patients, of all comers with AKI, there didn't seem to be anything new in this guideline from NICE. It was just highlighting AKI in COVID patients as an issue. So moving on to drugs and environmental toxins. So again, exam questions often like these types of clinical presentation because the biochemistry is subtly different. The actual way that the toxin causes the renal injury is subtly different, and often treatments differ between toxins. So for my exam, I built a huge table of all of the kind of drugs and poisons, but these are the ones I've picked out specific to renal. Obviously, things like paracetamol overdose and other drugs will cause liver injury and sort of associated, AKI due to multi-organ failure. But these are the ones I thought was often come up in relation to renal. Ethylene glycol causes an oxalate crystal nephropathy. The patients often present profoundly acidotic with a very high lactate. There's often a bit of a devil's in the detail in terms of the history as to are they a drinker or have they had lots of episodes of suicidal ideation. It's important to have an awareness of how to calculate their anion gap, which would aid you in the diagnosis, but it's not diagnostic. Serum levels are useful, but they often have to be sent to a lab that's not based in the hospital, and they take a very long time to come back. So they're not very useful in the acute setting. It's more of a clinical suspicion. Management used to involve administering ethanol, but I've never seen a patient being given ethanol for ethylene glycol overdose. What tends to happen more commonly now is people consider fomepizole, which reduces the metabolism of the ethylene glycol, and often they'll get, if they're in extremis, admitted to ICU, resuscitated fluid-wise, but then often will commence early hemofiltration, as the mainstay of management. I've got Dr. Malik here, one of our ICU consultants, who's going to do the next talk. He just joined us. Methanol is similar. Again, you get significant acidosis. You get direct renal toxicity from the actual formate, and you can also get crystal nephropathy as well. Treatments are similar, and again, patients progress to receiving hemodialysis very quickly. Other drugs such as MDMA, someone was mentioning MDMA as a possible cause in the previous scenario. Neuroleptic malignant syndrome caused by antipsychotics, serotonergic drugs causing serotonin syndrome. They all tend to get renal failure secondary to rhabdomyolysis and hyperpyrexia. The pyrexia, if it's extreme, can cause direct renal injury, but it tends to be the myoglobin for kidney injury that causes their AKI. They're often obviously hyperkalemic with a very high CK. They become acidotic. Treatment being to stop the precipitant, manage hyperkalemia. You can consider giving drugs like dantrolene if they're particularly pyrexial. Cipraheptine is in serotonin syndrome. And again, hemofiltration is our mainstay, really. But as people were doing in the scenario earlier on, people were doing basic management, ABC, hydration, volume status, and then consider your specific management measures. The most useful resources I found revising for my exam, I used ToxBase. I managed to borrow the local A&E's login just to have the summaries that I could access. A website called Life in the Fast Lane, I'm sure you're all familiar with that, has really good toxicology summaries for each of these drugs. And it also does some evidence-based assessment in terms of the management measures. The BJ education articles often address management of certain drugs. There's one on serotonin syndrome. I think that's probably because of drugs we might use anesthesia. There are other articles on patient planning with paracetamol overdose, for example. So it's worth having a trawl through if you want a good summary of a particular toxin, how it's managed. Have a look on those articles as well. I found a website called UKidney, which is an American website that again has single-page summaries on management of AKI secondary to toxins. Again, coming back to what I was saying earlier on about adjusting drug doses, I rely on the Renal Drug Handbook to dose adjust for patients. I think there's two sections on whether they're receiving intermittent hemodialysis or CVVH. So you can dose adjust drugs according to what the patient's GFR is if they're not on knee replacement therapy or if they're on renal replacement. So yeah, you can actually get that free, I think, on Google as a PDF. So it's worth saving to your phone. Right, so we move on to another OSCE question. So again, you've got a 69-year-old man who's admitted to ED with breathless confusion. I'll leave you a few minutes to have a look at his blood stuff here. And again, if you could just respond by answering some, putting the responses into the question box, that'd be really good. So have a look through. So it sounds like it's a guy who's in his 60s. He's presented with Kussmaul respiration. And he's looking through his bloods. He's profoundly acidotic. Lactate's not so high, but his base excess is -20. So the question leads you through like this. So what's the most significant abnormality? So I kind of said it already. It's obviously the acidosis. Suggest some likely causes. Yeah, so people are saying severe acidosis. Yeah, so toxins. Yeah. 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 So lots of options coming out here. So people are saying it could be toxin based, could be renal AKI that's progressively severe, could it be sepsis? Could it be the sepsis? Yeah. So again, you won't get away with getting through an hospitalization on anything without mentioning sepsis. Euglycemic DKA. Yeah, salicylates. There's all sorts of things coming out here. Yeah, fine. So what they're actually after here was, well, if you mentioned toxins, they then prompt you to ask about methanol. So what are the possible options? Another option that they permitted is ethylene glycol poisoning as well. So list the options as we've already just gone through. Fomepizole. Yeah, good. They're all coming out. That's great. Good. Yeah, so the college wanted fluid resuscitation, sodium bicarbonate if the acidosis is profound would be permitted, ethanol infusion, fomepizole, and then CRRT. But I think we all, as people have said, giving a big bicarb load. But I think, as we were all aware, this patient will probably be lined up and transferred to critical care, probably for some hemofiltration. But don't forget the other measures that you can initiate. That's good. So coming to domain 4.7, I'm going through my domains that I listed earlier on the talk here. College wants to know about initiation, management, and weaning renal replacement therapy. Now, Dr. Malek's going to do a talk in a second on all of the aspects of renal replacement on ICU. But I just wanted to highlight some things that cropped up in my exam about the things they wanted to ask and the level of questioning they wanted to know about. So there were loads of questions that came up, I think, both in my MCQ and SBA, and I think I had one question in my OSCE about indications for renal replacement therapy. So for my fallback list here, I've gone back to the NICE guideline NG148, which obviously suggests the obvious ones: hyperkalemia, acidosis, uremia, fan electrolyte abnormality, and fluid overload. There's also a few others as well. So they mentioned tumor lysis syndrome, urea cycle defects, something that I hadn't considered, but some dialysis patients are often patients with metabolic conditions who are dialysis dependent, not because of their AKI, but just to manage their ammonia load. It's an unusual one. They NICE classify it according to biochemical and clinical indications. I guess clinical indications are quite hard to grasp. You obviously want to assess somebody and their blood work and their other investigations before you just relied on a low urine output to dialyze them. But yeah, their clinical indications are refractory volume overload. End organ involvement seems to indicate the uremic complications. So if you don't have a urea on someone, but they're pericarditic, they're encephalopathic, they've obviously got uremic kind of appearance, and they've got platelet abnormalities, then you'd consider dialysis. Need to administer IV products and create intravascular space. I guess that's someone who must be extremely brittle from an intravascular volume status point of view, where there's someone who's got significant heart failure, and you need to generate some intravascular volume to give some kind of drug. I haven't heard of that one before. And then, more common ones are obviously poisoning and drug overdose, as we've mentioned in the previous scenarios. Severe hypothermia and hyperthermia. I have seen one patient who was put on a hemofilter with the temperature increased to warm them up. It was extremely cold. But again, that's pretty rare to start them on dialysis just for warming, really. As I say, we're going to talk about management of filtration a bit later on, but question themes could involve, they often lead on from a version, as we'll see in a second. You need to know about the types of line. You're often presented with a picture, and that leads into an OSCE scenario. Line-related complications in management obviously is an entire different talk on its own, but you could be presented with radiology or something like that with a complication associated with a renal line, and they might ask you some renal questions. You expect to manage, you have a working knowledge of heparin pharmacology and HIT, how you do a screen for that, how you do a score and then a screen. Citrate accumulation is extremely rare, and I haven't had any questions on that. I suppose it's possible they could ask you a question on accumulation of citrate due to the way it works in patients perhaps with liver failure, but it's very rare and is often used on liver units anyway. In terms of other things, you might also be asked, how you might manage assessing someone's volume status and deciding how much fluid to remove. You may also have questions on how do you adjust the relationship between the blood flow and the dialysate to accommodate for things like acidosis and alkalosis. So have a look at your local protocol, because there's often a really good stepwise approach on how to do that and what you should be adjusting first. We had a patient the other day who was on hemodialysis but was becoming increasingly alkalotic. We tried to decrease the blood flow, which is the first step, but the filter didn't like that due to, I think, some of the filter pressures or the flows. So the next step was to increase the dialysate, and it's that ratio that allows you to adjust the acidosis or alkalosis between the two. So again, this is a question that I had to come up in my OSCE. Question is, and again, I don't mean to patronise you, this is exactly what was presented in front of me, but what's this device? So again, if you could just post the answers on the chat box there, we'll see what people are coming up with. Yeah. 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 So the next question, I was asked a question directly on what was the middle lumen for, but as people are correctly identifying, it's a trialized catheter which allows you to give central drugs. So we'll go through to the next questions. What's this device? Describe its features. Sorry, that was the question. So they wanted you to describe in detail that it was a wide bore catheter, that it has a flow and a return lumen at different points along the catheter. It has clamps, so you can clamp the lumens. All of these things that I was saying, the guy was writing things down on his clipboard, so I guess there must have been, he was kind of, and then he asked me questions about the central lumen, and that's used to administer vasopressors usually for patients who need blood pressure support when they go on to dialysis. List 4 complications of insertion, yeah, so carry on guys, and again, they're all the standard line insertion complications, aren't they? Yeah. Yeah, so those complications are coming through. And then the next question was, list sites of insertion according to international guidelines. So yeah, we've got all the complications coming through, that's good. So just have a stab at writing down where, in terms of anatomical position, and what order you would choose for insertion of this line site. So what's your number 1, then put the subsequent ones after that. Yeah, good. Yeah, so as people are doing, they're going through the KDIGO guidelines of line insertion sites. So you have your right IJ, then your left, then your femorals, then your left IJ, then your subclavians. So it always surprises me that they want you to go for your femorals before your left IJ, but this is all due to flow essentially through the flow and efficiency of the filtration. So that's what KDIGO are suggesting, is right IJ, femorals, left IJ, subclavian. Good. We'll talk a bit about those guidelines a bit later on. Okay, the question then went on to ask these questions. So list 4 different consumables prescribed during initiation of CVD-HDS. So the station was literally like you were sat there about to start someone with a filter. So list some consumables that you need. See if you can think of all of them. So this tends to be more prescribed drugs. So yeah, any others? There's a few more things. Yeah. Yeah, so the ones they wanted are calcium citrate, dialysate, and priming fluid. I couldn't think of priming fluid as the one that I didn't get, but yeah. What are the parameters specified on the filter prescription? So what do you commonly prescribe, as part of the protocol? Yeah, filtration rates, yeah. The type, yeah. Yeah. Yeah, excellent, yeah. So people are saying dialysate flow, blood flow, fluid removal. Yeah. So the dialysate flow and the blood flow are essentially analogous for the dose of dialysis, which represents sort of the post-dilution mils per kilo. Yeah, people are writing, some of the prescriptions in the region might have pre and post-dilution specified on them as well, but they do on that one actually. So yeah, you're exactly right. People have got all of the ones there. Blood flow, dialysate flow, pre and post dilution, fluid removal. The other thing is protocols also specify an initial calcium replacement rate. That's based on the patient's pre-filtration calcium level, and then that's adjusted every few hours by the nursing staff according to the protocol. What about evidence guiding dosing? Does anyone know of any trials that we might use to decide our dose? Yeah. So yeah, people are saying 25 mils, 35 milligrams per kilo of severe multi-organ failure or sepsis. Yeah, that's good. And what study kind of hinted at those guidelines? Is anyone aware of the actual study? We'll talk about it a bit later. So the renal trial was a trial that looked at high dose versus low dose dialysis, and if there's any mortality benefit on ICU. We'll talk about that in a moment, but it indicated that there was no real benefit from running really high flows compared to 25 mils per kilo. How do the nurses monitor the regional citrate anticoagulation? What are they looking at? Yeah, good. All those questions are coming through. That's good. Yeah. So they're looking at the pre and post filter ionized calcium ratio. Yeah. Very good. The TI ratio as well. Good. Yeah. And final question was, the examiner said your filter is the nurses have concern about developing clots. It does clot. You put a new filter on. What changes can you make to your prescription to reduce the likelihood of coagulation? Yeah, there are lots of sensible options coming out here. So people are hinting at you can add pre-dilution. You can increase the amount of pre-dilution the patient's receiving. So that's basically crystalloid added or dialysate fluid added to the blood flow prior to it going through the CVVHDF canister. A lot of other people are suggesting a second anticoagulant or systemic anticoagulation, which is another option. You can increase the blood flow rate through the filter as a possibility. I'm not sure if our local guideline mentions doing that, but we focus, I think, on pre-dilution here, but it decreases the effectiveness of the filtration because you're filtering something that you're adding. If that makes sense. Good. Okay, so the next slide I've got is a summary of all the guidelines that I think you definitely need to read before you go into your exam. So have a look at the KDIGO. The last guideline was published in 2012. It incorporates all sorts of different things in relation to management of AKI. Kidney Disease Global Outcomes website, so Google KDIGO, they have other guidelines on management of the patient with CKD and management of all sorts of other medical problems, but it's the AKI guideline that's the most useful. That has sections on it which incorporate things like management of hemodialysis, options for anticoagulation and the like. So have a good read of that. Again, I can't recommend Think Kidney enough. It's a really good stepwise, grabbable thing for your exam in terms of managing any kind of scenario with AKI. It brings up pointers that are useful. And yeah, nice guideline, NG148 is the one we mentioned previously. My next slide, I've got a summary of all the things that I think are quite important, all the studies that I think are quite important to know. These often come from the Viva. You get asked a few questions in Vivas about, are you aware of any studies that demonstrate this or that? A lot of them looked at, on ICU, are we going to dialyze patients early in their admission, or are we going to wait till there's a very clear indicator for the dialysis? So these are often patients presenting with sepsis or multi-organ failure. Do they benefit from early dialysis for slightly weaker indications versus waiting for the absolute hard indications? As far as I'm aware, none of the studies show any benefit in starting it in CVVHDF in an accelerated fashion, and those are the ones that I've summarized there, except for a German study which showed survival benefit if you've got a patient who is in multi-organ failure secondary to post-operatively. I'm not sure if that's because of the surgical cohort of patients, but they tend to do better. That's the ELAN trial. The other one to mention is one we've already mentioned before, which is the renal trial, which looked at 40 mils per kilo versus 25 mils per kilo, and found no benefit in delivering higher intensity dialysis. So again, going into your exam, have a little list of studies, try and allocate them to a topic. These are the ones that I thought would be the most handy. Dr. Malik's going to talk a lot more about early versus late hemodialysis in his next talk in a second. I think that's about everything that I've got, really. It's a bit of a whistle-stop tour. As I say, I haven't discussed management of the patient with post-solid organ renal transplant. Again, that's quite a complicated topic. Have a look at the pharmacology of the immunosuppressants, because they often come up in multiple choice questions. But that's pretty much everything, I think. So has anyone got any questions, anything you wanted to ask me from the talk? I'm going to post anything in the box there. Someone said they just looked up acyclovir and it is dialyzed, apparently. So again, yeah, renal drug handbook, and there are, in general, if you have a patient who has a toxin that is water soluble, a small water soluble toxin, it'll be cleared by dialysis. But if not, if it's heavily protein bound, that or a large molecule, they tend to be the ones that aren't cleared by dialysis. But again, have a mnemonic going into the exam to look at the common ones, things like salicylates. Others are a bit more tricky, things like digoxin due to protein binding, stuff like that. So any other questions? Anything else anyone wants to ask?